Good morning and welcome to Bias in Healthcare, Creating a More Culturally Competent Workforce breakout session with Carmen Chinchilla, Executive Director of Specialty Societies, Nebraska Medical Association. My name is Anita Weiskup. I am the Native American Health Liaison Program Health Manager for the Office of Health Disparities and Health Equity for the state of Nebraska with the Division of Public Health. We're going to go ahead and get started, and just remind you that we will have a Q&A session after Carmen's presentation. So please put any of your questions into the chat box only, not into the Q&A box. I don't think that's even working, but only in the chat box. And we will go ahead and let Carmen start her presentation. Thank you very much, Carmen.
All right, welcome everyone. I'll get my slides going. And so I want to welcome everyone to this breakout session. I wanted to first thank our hosts and the event organizers for the invitation. I think this has been a great undertaking, and I remember going to this meeting in person pre-COVID, so it's nice to be a part of it today, even if virtual. I do hope that our discussion today will leave you with a clear understanding of bias in healthcare, as well as questions for your own personal reflection on how we can collectively improve to become more culturally competent and reduce our biases. Before we get started, I do want to just kind of say I caught a cold, kind of bad timing, and if my voice starts to go down and you can't hear me, please let our chat people go, or let them know, please. And as far as disclosures, I have no financial disclosures or conflicts of interest with the presented material. Our objectives for today include defining bias in healthcare, evaluating the impact of bias in healthcare, and finding strategies for improvement or mitigation. In my talk, I'll mostly reference physicians. This is the group that I work with the most. However, please keep in mind that you can substitute what I'm saying for any healthcare provider and pretty much for any of us as well. So, implicit bias. It is likely that one or more of these photographs make you feel comfortable, and one or more of these photographs make you feel uneasy. It has everything to do with exposure. Who, how, or how often you were exposed to any of these groups of people makes a huge difference in how we view each of the people in these images. What characteristics you attribute to each depends on that exposure. So for example, via personal experience, if you had more exposure to these groups, you might have more positive or negative feelings depending on that exposure. We also think about media representation. For example, if a certain group of people is always portrayed as the terrorist or the criminal, or any what we would consider negative attributes, then that exposure to constant media representations also affect how our implicit bias is demonstrated. And then upbringing is another big factor in implicit bias and how you attribute positive or negative unconscious feelings towards a person from a particular group. And I first want to begin by addressing the word implicit bias. It's kind of currently a buzzword, but some of the first studies of implicit bias actually date back to the 1990s. And we can find building blocks of these concepts dating as far back as the 1950s. And so with that said, I think it'd be the biggest understatement of the century to say that the world is a complicated place. Things are not black and white. And our minds do try to create ways in which to process all of the information that we get through our daily living. And so our unconscious minds then begin to create certain group associations on the basis of those experiences, so that when we deal with certain situations again or certain scenarios, our brain will know what pattern to follow. And so what can that look like in healthcare? Well, physicians and basically any healthcare provider are not exempt from that type of implicit bias. In fact, it is known that physicians have the same level of implicit biases as lay persons, as one of the studies has suggested. In a systemic review of implicit bias and racial and ethnic bias with healthcare professionals, it was seen that low to moderate levels of implicit racial and ethnic bias were found among healthcare professionals, and it was at a rate that was similar to those in the general population. And levels of implicit bias against Black, Hispanic, Latino, and people of color were relatively similar across all groups of society. So when we think about what that could look like in healthcare, physicians, like the rest of society, may unknowingly have those associations of certain groups with negative concepts and other groups with positive concepts. And so some of those negative concepts that we see portrayed, again, implicitly, is non-compliance, the idea that a certain group of people are less likely to follow the treatment regimen or less likely to be compliant. We also have this idea of lower competence. So the idea that a certain group of people, may not be understanding, when we all know that health literacy is relatively low in society, and everyone should be taught to at a certain grade level. And then the other thing is an increased engagement in risky behavior, the idea that certain groups of people tend to engage in more risky behavior that puts them at risk, puts their health at risk. So with implicit bias, even people that we consider as good people, such as physicians and healthcare providers, can unknowingly discriminate. So how do we measure implicit bias? The standard in the studies that I've reviewed to prepare for this presentation is the implicit association test. This test is currently maintained by a nonprofit named Project Implicit, and it was founded in 1998 by 3 scientists out of different universities, including the University of Washington, Harvard University, and the University of Virginia. Project Implicit Health is what it's called now. Was launched in 2011 and is currently led by two physicians, two professors, one out of the University of Virginia and the other out of Harvard University. So the implicit association test basically measures our attitudes and beliefs that people may be unwilling or unable or not even be aware that they have. So for example, one would hope that everyone on this call believes that women and men should be equally associated with science. And that might be something that you believe and you think that you believe, but like many others, once you've taken the test, you might be shocked to find that you associate men more with science than you do women. And so that's what some of these tests bring out. It's really what's in the connections that have been made in our brain. And if you think about that one example, how often are women portrayed in the media as the homemakers versus the scientists or the physicians? And so what is our personal exposure to women in science or STEM type fields? And so those associations start to create those attributes subconsciously. So Harvard University hosts these tests for free on their website. I've added the link on there, but if you just Google implicit association test, you'll be able to find it easily. and they're all free. There's a variety of the IATs that you can access, and I have to say I've taken a couple and it was quite opening. Once you think about what you personally believe versus what the implicit bias in your brains are doing. So how the test works is that it will basically measure the two concepts. For example, if you were put flower and insects followed by attributes of pleasant and unpleasant, normally you would think, oh, flower goes with pleasant, insects go with unpleasant. At least that's kind of how the test is structured. Then the instructions shift mid-test to try to measure how well you start attributing the different characteristics with each topic. So flower with unpleasant and insects with pleasant. And that difference in your performance and how easily you're able to connect those dots is how they measure your implicit bias using these tests. So I've taken just some screenshots of the tests that are available. You know, we find Asian, weapons, age, presidents, disability, religion, weight. We usually forget that there is a big bias against weight, and again, implicitly and sometimes, unfortunately, explicitly. Race, Native American, skin tone, gender and career, transgender, sexuality, Arab Muslim, and gender science. I will address Wendy Wells' comment that they tend to think the test is not accurate. I have to say that even with all my cultural competency training and all the different things that I've done in my work in public health, I was surprised when I took the test for the first time, and my gut kind of lizard brain reaction was, oh no, this test has to be wrong. There's no way. And the more I thought about it, the more I thought, this is implicit bias. This is an opportunity to learn. This wasn't something that was, I think our gut reaction sometimes is to say, oh no, that can't be true. In my heart of hearts, I truly believe this. But I think our brain makes that connection just in order to help us navigate the world for good or for worse. So that said, I do want to address one thing, and that is what implicit bias is not. We hear a lot about what it is, but we need to make sure that before we continue, that we emphasize that discussing implicit bias is not explicit or conscious beliefs. So this means that racism, sexism, homophobia, and all of the other conscious beliefs that certain groups of people or demographic groups are inferior or less deserving of opportunities does not factor into this conversation. That those types of isms and phobias are not part of implicit bias. They are at that point explicit, and obviously choices that people are making to treat others differently because they don't feel that they're equal or feel like they're less deserving. And I think we can all agree that the detrimental effects of explicit bias have been pretty well documented throughout history and continue to affect society today, unfortunately. So what is the impact of implicit bias on healthcare? Well, the impact of implicit bias on healthcare does not really begin when at the physician level, when the physician is with the patient making decisions on their health or on treating them. It really starts at the applicant level, at least in my current sphere of work. So as you're likely well aware, there's a really long road ahead for someone who's interested in becoming a physician. They must first attend college or university, taking pre-med courses, taking biology or chemistry as their major, for, for 4 years or whatever it takes them to complete the pre-medical school training. And after that, they must be accepted into medical school. They must, for the most part, although this is kind of controversial and a lot of schools are removing standardized testing, there is standardized testing, the MCAT that they must take and be accepted into medical school. And that includes a committee, an admissions committee to do that. After that, there's another 4 years of schooling and then they must be accepted into and complete a residency program, which depending on the specialty could either be anywhere between 3 years, which is the lowest, and 7 years. And then if they wish to subspecialize or complete it to any type of fellowship, there's additional training for either a year or 2 years. So it's a really long road ahead, and there's a lot of gatekeepers along the way for anyone wanting to become a physician. So we have admission committees and their own implicit biases as one of those gatekeepers. We're all humans, and admission committees are, usually composed of physicians and unfortunately also have those implicit biases. So cardiologist Quinn Capers recently conducted an experiment within his own medical school program and found that a majority of their own medical school admissions committee members hold negative unconscious association. So again, the implicit bias part, not explicit, with images of Black people and homosexual people. The committee was also more likely to associate men with career professionals and women with homemakers. And he used the implicit association test, the IAT, to get this done. And so when we begin to evaluate just how that can impact diversity in the healthcare sphere and in the providers that are admitted into these programs, we can start to really question, how can we continue to be diverse if the admission committees, the gatekeepers to even get into these programs, are subconsciously choosing white applicants over Black or people of color, men over women, heterosexual candidates over those who identify as LGBTQ+. So, at that point, we start to question how much more diverse would our healthcare providers be if the gatekeepers themselves were more aware of their implicit biases and took strategies to mitigate that. And so, the lack of diversity in healthcare, it's believed that it can be a driver of healthcare disparities and disparities in healthcare outcomes. So some examples that have been studied include even difficulty in getting appointments. So one of the studies that I was reviewing for this presentation showed that for a mental health provider, so this was a psychiatrist, the people who called all had insurance, they were able to afford to go. And the study demonstrated that even just to establish care at the psychiatric clinic, of those who called, 28% of the white patients were able to obtain an appointment, compared with only 18% of the Black patients and only 8% of patients with lower socioeconomic status. And there's another point of implicit bias, is also socioeconomic status. And we sometimes forget about that it's, beyond the race and ethnic and female gender, but also socioeconomic status is a big one. So Dr. Capers, the cardiologist I referenced earlier, even looking within his own program, started to notice that when his trainees So those people who were under him and getting trained to be cardiologists were working. He noticed that when it came to people of color, there was an increase in drug testing and HIV testing for Black and Hispanic patients. And he goes on to say in his article that this was a point of opportunity, a teaching moment for them, an opportunity to learn and not so much to admonish them, but to make them aware that this was happening, because for the most part, they weren't aware. And that's where it gets tricky to make changes if we don't know what we don't know. And it's also no revelation that for members of the trans community, they definitely experience difficulty in finding primary care needs that is competent in delivering care suitable to their needs. And so despite the many studies, it has been difficult to find a direct connection between implicit bias and healthcare outcomes. That's not to say that there isn't one, but that when it comes to outcomes, that direct correlation just hasn't been found. That's not to say that there aren't effects, just that they can't trace healthcare outcomes to only implicit bias. There's so many factors that affect healthcare outcomes in this country that they can't just narrow it down to one. However, implicit bias is more frequently associated with patient-provider interactions and relationships. So one study determined that some associations between implicit bias and the patient-provider interactions affects treatment decisions, treatment adherence, which in turn then affects the healthcare outcomes. So people of color are generally less satisfied with their interactions with healthcare providers. And what the study found was that the communication styles between white patients or higher socioeconomic patients are different than when it comes to people of color or people in minority groups. So one thing that was noted was the dominant communication style, and that's when the physician is the one who is leading the communication, not interacting with the patient, not asking questions. There was fewer demonstrated positive emotion, so less smiling, less of that cordiality, trying to make that connection with the patient, infrequent requests for input about treatment decisions. And they found this in cancer patients, unfortunately, where, we had more of that top-down mentality versus the physician working with the patient to request input on what their treatment decisions and what that would look like, and less patient-centered care for people of color. And I've been seeing some movement in the chat, so I'm gonna go ahead and just kind of look at what you guys have been mentioning. So Megan Kalpenhafer, my friend recently said that networking is not a barrier to getting jobs, because once you get the job, it becomes about whether you have access to your community. The presence of your community is what has helped her to navigate conscious and unconscious biases. Teresa J's, discrimination about women who are overweight, very true. Christy Abdul Green, my husband is the program director for family medicine, and all of his 8 residents starting in July hail from countries outside of the United States and bring to the healthcare system various cultures, languages, and experiences. It is really wonderful. That said, it would also be great to have more, I forget what BIPOC stands for, but who grew up in the United States. That is true. Once I asked a local nursing school program about what could be done to get more minorities into the nursing program, and the response was they often have issues with having to check on family members, family issues, pick up children, etc. So they have to put on the back burner because they are unable to work with them, accommodate them. I thought to myself, why not consider adding breaks throughout the day at strategic times to make this an opportunity more equitable based upon this knowledge? And Gail, some of the schools I'm familiar with, I've heard of programs where they have on-site childcare for their students, to try to accommodate people with children, because parents exist and parents need that help if they're going to try to finish school. Let's see. The Nebraska Bar Association, local law schools recently partnered to create the Nebraska Legal Diversity Council Pipeline Access. And yep, definitely we'll be talking about pipeline and Black, Indigenous, and people of color. Thank you, Tina. So continuing on, some examples of physician implicit bias, racial healthcare disparities and how physicians manage pain are pretty well documented. Physicians are more likely to prescribe analgesics for white patients than for Black patients. And just this morning, and one of the things that I do is I work with anesthesiologists as well, and that was reiterated in one of the articles that I received this morning, just out of the blue. And then other examples include the degree of verbal dominance and patient-centered communication. And, that's something we talked about in the previous slide. So they've done studies where physicians are recorded, and then the audio tapes were scored to determine things like the degree of verbal dominance and patient-centered communication. And for Black patients, the physician bias was seen through greater verbal dominance, which I discussed, reduced sense that the physician was liking the patient, and confidence in the physician. I mean, the biases work both ways, right? So if I'm a person of color and I've only had negative experiences with physicians because of their own implicit bias, then my brain continues to make the connection that physicians are not to be trusted, they're not to be liked. And we can think about what kind of, what that does to our society, especially, for example, in the pandemic, where science, was just not seen as something that was as factual as science is, or we see it with vaccine hesitancy as well, just these negative stereotypes and implicit biases based on experiences just aren't conducive to people adopting recommendations from the medical community at that point. And then just to share from my own personal experience being Hispanic, this was when I lived in a different state, but I'll never forget this experience when I took one of my non-English speaking family members to the ER, and this person was admitted. They didn't speak English, so I thought I was being a good patient advocate and asking questions on behalf of my family member. And it was my first time managing the system and helping someone get admitted to a hospital. You hope that you don't have to do that very often. So I asked a very simple question. Will the hospital provide her with her current medication regimen, including her pain medication? And this was back in the 2010s, early 2010s. So, I at that time had no idea how long the person would be at the hospital. And I wanted to be sure that they would be pain-free, right? Like, you want your family to not have pain. And then that was the only question I asked when it came to pain. They answered and said that they would take care of the medication. But then I had friends in the medical community who were able to look at their chart to kind of see what they were thinking about how long she'd be there. And they had labeled her as drug-seeking behavior. And I was shocked. My friend was like, "What did you say?" I said, all I asked was where they were giving her pills. I mean, this family member was older. They were in their mid-70s when this happened. they were scared, unable to communicate. So when we start to think about, at that time, I didn't think about it as implicit bias, but that's very likely what it was. The white physician who was treating and admitting her, as soon as I asked that question, put in their chart something that would affect the way the rest of the hospital staff would treat her. Because now she's not a patient in pain. Now she's someone who's drug seeking. Will they take her seriously? Will they take why she's there seriously? And the idea that how that interaction went and how what I thought was a simple question could lead to something like that, I think just really opened my eyes to how little things about ourselves and our interactions can really trigger those implicit biases. So I do have a video, and I think we still have some time. Nebraska Public Media put it out through PBS, to try to unwrap these implicit biases. So I will do a new share. Let's see. Okay. Please let me know if you can't see or hear the video.
Implicit bias exists when we unconsciously hold attitudes towards others or associate stereotypes with them. For example, we often harbor negative stereotypes about others without consciously realizing that we do so. Implicit bias, which is also called unconscious bias or implicit social cognition, is a prejudice that is deep-seated within the brain, below the conscious level. Studies have demonstrated implicit bias against racial groups, genders, LGBTQ, and other marginalized groups. We may even be prejudiced against our own group, although we tend to favor our in-group with positive stereotypes and disfavor out-groups with negative stereotypes.
The immediate feeling you get or the immediate thoughts you have about a person, an assumption you feel, just anything you feel really stems somewhere from an experience you've had or your upbringing.
Depends on the region you're from, the country you're from, the background you grew up in. That shapes the person's unconscious bias.
I think sometimes you don't even realize it, but your own actions, maybe the way you treat others as opposed to treating others that look like you or that act like you or that are your friends.
Implicit bias often runs counter to people's conscious, expressed beliefs. Few physicians espouse racially discriminatory views, and yet doctors tend to recommend less pain medication for Black patients than for white patients with the identical injury. In other words, people can be explicitly unbiased, yet implicitly biased, according to psychologist Daniel Kelly and colleagues.
One of my closest friends since high school, we've worked on a lot of projects together. We've been in a lot of classes together. Sometimes we'd be working together in a group project, for example, and she would say stuff like, oh, you're good at math, you're good at science. Here, you can take this part of the project or something. I don't hold it against her or anything, and she doesn't mean any harm by it. But obviously there's that implicit sort of bias or stereotype that Asians are better at math and science.
Implicit bias has been found in a large array of studies using various tests, but much of the evidence for the phenomenon comes from Harvard University's Project Implicit website, home of the Implicit Association Test, or the IAT. Literally millions of people have visited this site and taken various tests that ask them to respond rapidly to questions that require them to associate Blacks or whites, males or females, or young or old, etc., with positive or negative words.
Most of the implicit biases that I've run into are probably positive ones, things that come with being white male and having height and having a good voice and things like that.
Professor Nosek and colleagues tested more than 700,000 subjects and found that more than 70% of white subjects more easily associated white faces with positive words and Black faces with negative words, concluding that this was evidence of implicit racial bias. In fact, additional evidence indicates that measures of implicit bias better predict people's conduct than measures of explicit bias.
I think that if you are anyone, to be blunt, that it's not a white male, you potentially feel that implicit bias. Maybe you're just looking for someone that is like you because you like you. And so you want to be around more people like you. But what's really rooted under that is that you potentially don't think that someone else is as smart or as capable. And that is coming from a place of implicit bias.
Now, here's some good news. Various scientists have criticized the IAT. They point out, for example, that individuals who take the test on different dates often score substantially differently. Even IAT supporters admit that implicit bias, at least as demonstrated by the test, is widespread but relatively minor and has only a small impact upon people's real-world actions. In other words, the results of the test are not strong enough to predict particular behaviors by individual people. However, let's not get too comfortable. Even if the IAT cannot predict the future conduct of any one individual on a given occasion, it still indicates how groups of people will act on average, and that is worrisome. For example, few people openly advocate for discrimination in hiring, but white applicants receive 50% more responses from potential employers than do Black applicants with the same resume. Likewise, college professors are substantially more likely to answer student emails if the students' names indicate that they are probably white than if the names sound like they belong to Black students. And in one study, online course instructors were 94% more likely to respond to discussion posts by white male students than by other students.
There are a lot of opportunities to promote people within the workplace. It doesn't happen because of different biases. People assume, a woman is of a certain age or they're married and you think, oh, she's going to want to have kids, so we're not going to give her this really tough, big project.
When I graduated from West Point in 2009, I went to my first organization, the first unit assignment. I was the only Latino officer in a group of about 100 other officers. Yeah, I think there was a lot of hesitation in really following my lead as the leader for the organization. I think it hindered in some way, the ability for us to build cohesive trust within our organization, and really have that going into a combat environment.
Because implicit bias operates at a mostly unconscious level, it is difficult for individuals to overcome. No existing training regime has proven particularly effective at debiasing implicit bias. But fortunately, some research shows that stereotypes can be unlearned and that safeguards can be put in place to minimize their impact. For example, women used to make up only a relatively small percentage of the musicians in orchestras. But when orchestras began holding blind auditions, where the applicants played behind a curtain and their genders were unknown to the judges, the percentage of women chosen to play in symphony orchestras doubled. Perhaps we can put a dent in implicit bias after all.
These biases are sometimes so deep-rooted within us or within our culture that we don't even realize that they are biases.
We can have a mutually, beneficial conversation and really benefit from learning from each other and really understand that we're all not that different.
Listen, really absorb the experiences of those around you, especially those who come from backgrounds that are unlike yours.
Learn something new about a person, and then that will kind of help shift that bias, because now you've actually asked that person, or now you get to know that person.
There's so many opportunities to engage with others, to say, I don't want to do this again. Can you help me not do that? And people are willing to have those conversations.
That was just a short video to kind of lead us into the next segment, and our third objective, which is learning some strategies to mitigate these biases. At the end, they said that there weren't any proven strategies, but there are strategies to mitigate and help us kind of unlearn those connections that our brain has already made. So, we've reviewed the bad and the ugly, so we can now go ahead and review the good. And so based on some extensive review of controlled laboratory studies on the malleability of implicit bias, one researcher, Des Gupta, he concluded that we can be optimistic that implicit bias can be reduced through two mechanisms that he highlights. And one is the training mechanism, and the other is the environmental intervention. So with training, the idea is to gain more cognitive control over your negative stereotypes. So repeatedly making mental associations between attributes that are positively valued with the group that you think of as bad. And so obviously for that, you kind of need to know what your biases are. So I would say that the first step really is to understand what your biases are. And I really do think that the IATs are a good way to do that, or a good jumping off point. And with the environmental intervention, it involves more increasing exposure to those people who you are usually stigmatized, or who you have found out you have implicit bias against. And so these are some of the interventions that we've seen have worked. And then, some we can do at a systemic level, and some are strategies that you can do at the individual level. So going back to our initial conversation about diversifying our healthcare community, at an admissions committee level, Dr. Quinn Capers, again, the cardiologist, one thing that he had his committee do was removing any photos from the application files. He had everyone in the committee take the implicit bias test, the IAT, to just create that awareness, because again, you don't know what you don't know. And then he did host a bias reduction workshop for committee members. I'm not sure what their workshop entailed. My conclusion is that it was likely some sort of cultural competency type workshop. And then this one's a bit more controversial, although I feel like more colleges and universities are starting to do this, where they begin to remove the academic metrics. So those are your MCAT scores, your standardized testing scores, and this USMLE score, that's the standardized test you have to take to be accepted into a residency program after medical school. And he's found that really has worked. He said that after the first year of implementing those guidelines, that their next class of incoming residents for cardiology was the most diverse that they'd had. And so what they do now is that every year it's a conscious decision by the organization to continue to do this, so that it's a continually improving process, and not just something that, oh, we did it that one time 3 years ago and now everything's okay. It's something that they continuously try to work on. When we talk about at a patient interaction level, he came up with some other successful ways to help reduce the negative implicit bias towards any patient. So the first one is that common identity formation, and that's trying to have the physician and the patient discover something that they're both that connects both of them. So for example, liking a specific type of music, discovering that maybe you're from the same hometown. Nebraska is still a pretty small place in terms that a lot of people know each other. And so I think that one's an easy one. Sports team, it can also be easy. especially here in Nebraska with the Huskers. Finding common hobbies, finding that common association, it definitely helps to recast, whether it's the candidate or the patient, it recasts them in a different light. And now they're a fellow of your group and no longer perceived as this outsider, and this helps to lessen the implicit bias when it comes to treatment and how the physician talks to them. The other is perspective, putting yourself in the patient's shoes. And we talk about this empathy with the patient, visualizing what their life would look like on a daily basis. You might have a patient, for example, who you might consider non-compliant, and maybe they're not compliant and they just don't have the means to be compliant. If the doctor tells them, you really have to exercise, but they don't have a place where they can safely exercise, are they able to afford their medication every month? Do they live in a food desert and have trouble accessing healthier foods? So this perspective, in public health, these are all social determinants of health. And for physicians, unfortunately, a lot of them are only starting to adopt some of this language of trying to think about medicine, not just in a medication way or in a, do this and you'll get this kind of way, but in a more holistic way where you're looking at the life of the patient, considering all the possibilities. So Dr. Quinn says that, you take a mental pause to review all of the data of the evidence and try to find evidence of the opposite conclusion. So kind of creating a pro-con list. So for example, in the personal example I used of my family member being labeled drug seeker, what if the doctor had taken a mental pause and instead of just, oh, brown person asking about pain medication must be drug seeker, what if he had taken all of that data that he has in his hands in her chart and thought, oh wait, this person has this and this disease, they do need that medication, was there evidence to support some other conclusion than his initial gut feeling? And then another strategy is that counter stereotypical exemplar. So focusing on individuals that you admire who are part of the same demographic as the patient or the same demographic as the one you have a bias against. So that could be a colleague or a friend or a neighbor, people that you know that you respect. And then you're like, no, they're part of that group too. So some additional strategies, we have mindfulness, increase. Unfortunately, I feel like these past 2 years, there's been, at least for our medical community and our public health community, with the pandemic, there's been a definite increase in stress and preoccupation, and unfortunately, it has been shown that it increases the opportunities for implicit bias to intensify when you're under those high stress situations. And so it's been harder to practice ways to reduce your stress in order to check your own behavior and check your own implicit bias. Checking your messaging is another one that we can do at an institutional level. So a good one is making sure that you're embracing evidence-based statements. What kind of messaging are you sending with how you're communicating with your patients or with any group of people. And then institutional procedures. So that's promoting procedural changes at an organizational level towards more healthcare equity. So for example, are you having those cultural competency trainings for all of your staff? Are we having images in the waiting room? Like how many times do we see pictures in waiting rooms where it's only one group of people? Trying to find your organizational blind spots the same way that you would try to find your own implicit biases. And that brings me to cultural competency training, which I'm a big fan of. You can do this on an individual basis. You can do this at an institutional level. It's one of those strategies that I really do think provides a really well-rounded way to address implicit biases, because it teaches us to view bias not simply through a racial lens, but through a lens of culture, which, I've added the image here, but includes a lot of different things such as history, shared experiences, generational cultures, national or regional origins, class, gender. And we kind of sometimes forget about those. And I also like cultural competency training because we have national standards that we hope institutions will adhere to, with the national, cultural, and linguistically appropriate services or class standards. Having interpreter and translation services is another big one. By law, patients are supposed to have language services if English is not their first language, but depending on the state, sometimes that's not a reimbursable service for the physician office. So how can we advocate through our legislature even for something to, that makes sense on a cultural level and on a patient safety level to be reimbursed so that service is always available. So, I mean, these are different strategies and that should be reevaluated periodically. I noticed somebody on the chat mentioned, how can we do this when it interrupts our flow of work? Well, people who are CPR trained, for example, it requires retraining after so many years. I think it's every 2 years. And implicit bias training and cultural competency training should be at that same level of, your CPR retraining, or if you're a medical professional, you have a continuing medical education or continuing nursing education. We have to do those CEUs. So why would we not add this, since we know that it does have an effect on how we treat patients and on their healthcare outcomes? So that kind of retraining needs to continuously happen. And so obviously, our long-term vision, is equitable access to healthcare for the workforce. I've added this chart. It's from the 2018-2019, but you can really see the highest percentage of medical school graduates for that year was white. Here's Hispanic, here's Black or African American, Asian, and see, I can't read these very well, non-US citizens, unknown, or people who just didn't label, multiple race, and this yellow is other. And with that, it really shows you how non-diverse our workforce is when it comes to physicians. I mean, we know that, for example, there's I think for our last census, it was 18% of the population is Hispanic, yet they only see 5% of that in physicians. I think at the last census, it was close to 14% for Black or African American, and they only see that relate in 6.2 of their physician population. And it does have an effect when people don't see their own culture represented in the people taking care of them. So unfortunately, diversity and inclusion programs have really long been considered kind of an add-on. But then as we seek to eliminate the implicit bias and improve cultural competency along the way, I really think that we can have long-term and systemic change that will in fact enable equitable access to the healthcare workforce for anyone. And so when we discuss about the long road of training for physicians, the goal is really to help improve that pipeline so that we have a more diverse workforce actually make it to the finish line. So, at the realm of my work here at the Medical Association, we have a limited effect in what we can do, and so it's really up to the community as a whole, as represented by people who are attending this conference, to help work on the rest of the pipeline. So this would include, reducing implicit bias at earlier levels of schooling, and that could look like, the guidance counselor who takes a student under their wing, the science teacher who becomes a mentor. If we can have those biases decreased at that level of middle school, then we can start to think about the diversity of who is getting that extra attention, who is getting that mentorship. And then as representatives of the public health community, supporting pipeline programs. There's some pipeline programs throughout the country that even start as young as kindergarten. And so those try to help decrease the shortage of the healthcare workforce, but also engage and propel students who may not otherwise be able to have that opportunity. Some kids don't know what they can achieve until someone tells them, you can do this. So improved healthcare outcomes by eliminating implicit bias and creating a more diverse workforce is truly a realization of our public health values come to life.